As Kelly had said, I'm Dr. Lind. Kind of grew up and trained here in Wisconsin mostly, so happy to be back in this Stoughton and serving the small communities that we do service. Here's our beautiful new outpatient center. If you haven't had the chance to see it or come to the open house, so I guess getting into it, kind of what are we covering today? So we'll be covering ankle sprains and instability, ankle arthritis, and cartilage defects, and we'll kind of briefly touch on peroneal tendonitis as well as superficial peroneal neuritis. So we'll go a little bit more in depth on sort of sprains and then some of the consequences that can happen following ankle sprains, which include these listed here. So other causes of ankle pain, this could be a 2-week lecture if we went through all of it. But here's some other things that we're not necessarily going to cover today, but, gout infection, fractures, systemic conditions such as rheumatoid arthritis, reactive arthritis, scleroderma, lupus, just to name a few, as well as some biomechanical influences such as flat feet and high arch feet can kind of adjust how stress moves through your foot and through your ankle. And then, nerve and vascular related complications, poor blood flow can cause pain, as well as things like fibromyalgia and that sort of thing can cause foot and ankle pain. So we're not necessarily covering these exclusively today. But just kind of a general overview of some ankle pain complications. So this is, for anybody that's squeamish, this is the only, I guess, partially striking image that'll be in here. So just to kind of give you a general idea of, kind of what the ankle joint is, and kind of the ligaments that make up what we're going to be talking about today with lateral ankle instability and sprains. So you can kind of see here your tibia is your shin bone, your fibula sits on the outside. You have this, if we go over here, you have this anterior talofibular ligament as well as a calcaneal fibular ligament. These are the two most common that are injured in sprains. And then you can kind of see here sectioned our tendons. These are the peroneal tendons that sort of course from the outside of the foot and back up and around this fibula here. So like I said, the ATFL here and the CFL are kind of the most commonly injured in the ankle sprains. And then you can kind of see with its close relation and the fact that it's part of the capsule why you might have some other issues following an ankle sprain. So I guess what is it at a baseline? So typically this is an inversion injury, and I'll kind of show you on the next slide what that means. But you can also have an eversion injury that affects the ligaments of the ankle. These are very common, estimated 23,000 per day in the U.S. and most commonly after falls or walking on uneven ground if you have, history of and have instability. So again, the ligaments that are implicated are the ATFL, the CFL, and then there's the posterior, which is less commonly injured. And then here's kind of showing you the inversion ankle sprain and kind of the position that your foot takes, and you can kind of see how and why it would stress and tear these ligaments based on that position. But we kind of look here at the ATFL and the CFL, and then your PTFL, which again is typically not ruptured or torn. So an ankle sprain, so signs and symptoms, you have pain, swelling, redness, bruising, difficulty with weight bearing. You can have a feeling of weakness or instability at the ankle, stiffness, burning, numbness, tingling, and then a popping or snapping sensation. This can happen at the time of injury as well as, sort of a sequela or, a consequence of, having a long-standing ankle sprain and some of the injuries that can also sort of come from that. So typically, pain, swelling, bruising is worse within the first, sometimes week, sometimes 3. Typically, the amount of bruising, the amount of pain, and the amount of swellness sort of correlates with the amount of damage that's there. It's not always the case, especially when we talk later about how much damage can happen to the cartilage in the joint itself. That's not always apparent initially. But typically, the more bruising you have, the more difficult it is to put weight on the foot, or having an inability to put weight on the foot tends to lead to, higher levels of damage. So, when we're looking at ankle sprains in general, typically there's grades that we discuss. And again, this kind of goes hand in hand with that sort of level of injury, level of instability. So grade 1 sprains are typically stretching or small tears. And again, the most common would be your ATFL, and then the CFL would be your second most common. Grade 1 would be stretching or small tears. Typically, this has little to no bruising, typically painful for maybe a day or two. Most people can walk on these right away. You've probably had this in your life if you've kind of misstepped, rolled your ankle, and had just kind of slight pain and a little bit of swelling to the outside of the ankle. It's probably a grade 1 sprain. Grade 2 sprain would be sort of a larger but an incomplete tear. This is where you start getting into some, lighter bruising, more painful to initially walk, but you're still kind of able to, and there's really no instability per se to the ankle joint itself. And then a grade 3 sprain would be kind of that complete tear. This is where most people have a complete inability to put weight on it without being significantly in pain. You can start noticing quite a bit of bruising involved, and it's a lot of swelling associated with that as well. So when we're talking ankle sprain treatments, typically the initial ones are RICE, rest, ice, compression, elevation. So this helps alleviate pain, reduces swelling to the ankle. You can add anti-inflammatories such as ibuprofen or naproxen. It may include periods of immobilization with a walking boot, with or without crutches, and kind of controlled weight bearing in the boot, sort of depending on the severity of injury and pain. Again, lower levels of injury are going to be more susceptible to immediate or early weight bearing as long as it's protected. Those grade 3s sometimes can take 2 or 3 weeks to really be able to start walking on them. Physical therapy is kind of the cornerstone for treatment, especially once you have the ability to start walking, and we sort of ice and elevate and all that, and we start getting rid of some of that swelling, you get rid of some of that pain, you're able to start putting some weight into it. That's when physical therapy really comes in and starts working on you sort of strengthening flexibility, stability, and kind of the motion of the joint, because you're going to stiffen up a little bit following that just from the swelling. And then ankle bracing and during activities. So some people see bracing long term as a an inconvenience. I would argue that Andy Murray here seems to have done just fine, wearing bilateral ankle braces. And again, he's kind of at the top of the world as far as, tennis goes. And that's a lot of lateral movements, which puts a lot of stress on the ankle. So, sometimes bracing is necessary, or at least, can help with activities. When you get into, failed treatments of physical therapy, still having pain, or if there's just lax, the ligaments are too lax, they haven't quite healed correctly, there's instability, there's recurrent ankle sprains that just never quite seem to heal. We do have the ability to go in and repair those ligaments. This kind of bottom left here just kind of shows you a general idea of about what the incision would look like for that. Typically, we add arthroscopy, or going into the ankle joint with a camera, as well as a shaver. And the reason for that is we'll get into a little bit later, is there tends to be quite a bit of damage that happens within the ankle joint and the capsule of the joint itself. So if it becomes an issue where there's, kind of chronic ankle pain and laxity associated with these ligaments on the outside of the ankle, we do usually add an arthroscopic evaluation to see what kind of cartilage damage there might be and sort of what the joint capsule itself looks like. For real recurrent injuries, sometimes these ligaments are sort of not viable, so we will occasionally add sort of a suture tape. It's an industry-driven type product. But these basically act as a seat belt. So, we attempt to repair the ligament as best we can, and then we sort of lay these over the top in a pre-tensioned fashion, or a fashion where if they don't have stretch to them, when they're at full length, it would be in sort of that position where you would start to have that inversion type injury. And this sort of, like I said, acts as a seat belt where it would stop your foot from going into that, type of position. So, for anybody recurrent, or some people with Ehlers-Danlos or ligament laxity type, real lax type diseases, we do occasionally add this as a primary option as well. And then again, let me move this, and then over on the right side here, you can kind of see this is another one of those where it's more of a more robust fixation with an anchor in the fibula. So what are some kind of common complications that we can see from ankle sprains? Again, chronic instability, cartilage injuries, superficial peroneal neuritis, peroneal tendon injuries, and ankle arthritis. So we kind of already touched on the chronic instability And that would be one of those things where if you're still having the sensation of sort of weakness, your ankle constantly giving out, or you're, every year you roll your ankle, or, you kind of can't do activities without, feeling uneasy on uneven ground. That's where, that arthroscopic and ligament repair would kind of come in. And then again, we'll kind of move through these. So cartilage injury, or otherwise known as an osteochondral defect or an osteochondral lesion. So, what is it? It's a compression. It can be a fissure. It can be a cartilage fracture with or without displacement of the fracture. And it can be cystic changes as well that develop under the cartilage. Some symptoms of these can be pain within the ankle joint with activity, typically alleviated by rest. Clicking or catching sensation within the ankle joint, swelling around the ankle joint, typically worse with activity. And then you can have some stiffness or some limited motion associated with these as well. So, how do we diagnose these? So typically when you come in with ankle pain, you're going to have an x-ray of the ankle. And none of these are patient specific to me. They're all just images online, but you can kind of see with this individual ankle imaging showing kind of this irregularity at the ankle joint. Otherwise, mortise is intact. So no real dislocation or subluxation or fractures of any kind, but you kind of see this irregularity. So from that point, you can move through and get an MRI or a CT scan to sort of further evaluate what this looks like and sort of further classify it. So you can kind of see here, and again, this isn't the same. This isn't a CT of the same ankle, but it gives you kind of a general idea of a CT scan that kind of shows this complete fracture that's non-displaced, meaning it's still exactly where it's supposed to be. It's just a complete flat fracture that goes all the way through that fragment. And then we stage these just like everything else. So there's a stage 1 would be more of a contusion, sort of a bone bruise, if you've heard of that term before. Sometimes you get just a small fissure or a defect in the cartilage. 2A would be sort of, an incomplete fracture. Stage 3 would be a complete fracture that's non-displaced. And then stage 4 would be a complete fracture where that fragment has actually moved from where it's supposed to be. We can also evaluate these further using arthroscopy again. It's not typically done as a diagnostic procedure. Typically, if you're performing arthroscopy, it is with the intent of you've already had the other imaging and you're going in to do something about it. There are places, and we do have access at Stoughton Health to use a nanoscope, which is a very small sort of camera that we can put into joints. There are some places that will evaluate the cartilage and stick that into your ankle within clinic. I sort of reserve that in the operating room just from a risk of infection standpoint. And again, here, kind of showing an MRI of, with a cyst essentially that's developed under. There's fissures within the cartilage, and this white circle here is a cyst that is developed, basically just a fluid-filled space. And one of the downsides to these is that because you have a fracture, if you have fissures, when you walk, the fluid within the ankle joint is under pressure and can sort of seep in through those cracks and cause damage. So when it comes to osteochondral defects, how do we treat these? So typically it's non-operative as an initial treatment. Activity modification. Some people will notice, because these lesions tend to be either on the medial side or the lateral side, they're very rarely central. So people might notice, pain or catching or clicking with a certain foot position or a certain activity, or during yoga, during a certain stance. They'll notice pain during that, but they won't necessarily notice it with just sort of day-to-day walking around. Or they might get those random sort of tinges where it hurts a little bit here and there. So activity modification. Sometimes we immobilize, and again, it kind of depends on what the lesion looks like, what the staging is. If the effort is to have that fragment, that sort of stage 3 where it's a full fracture all the way through, but it hasn't displaced, we can utilize a 6 to 8 week sort of immobilization, meaning either not weight bearing for some portion of it, or partial weight bearing, protected weight bearing in a cam boot, in a boot, to try to get that piece to sort of heal back into place. Typically you wouldn't pursue that route if it was a dislodged fragment, because it's not going to sort of sit back to where it was supposed to be. There are platelet-rich plasma injections that we can utilize that sort of decrease some of the inflammation and the damage that's been done. There's not great literature on these in the foot and ankle specifically. They are used quite frequently in the knee, but it is an option. And then physical therapy, again, it's one of those things where if we're talking about these in the setting of after sprains and after injury, physical therapy again is kind of the first line treatment of getting through the stiffness that might be there, and kind of mobilizing some of that edema, that swelling that's there. So typically the non-operative management is advocated for about 6 months, with sort of a reassessment to determine if you have sufficient sort of symptom alleviation and activity level. Some surgical options are typically excision of fragment and or the loose cartilage and microfracture, otherwise known as bone marrow stimulation. So if we kind of talk through this isn't, again, any of my patients, but this is sort of the cartilage here. This sort of white, off-white is the cartilage. So this would have had some sort of injury. It could have had a defect or, some fissures through it. And sometimes it's what we call sort of trampolining. So if when you go in there and you press on it, the cartilage should be firm. Sometimes you see these lesions that have the bone underneath is sort of resorbed due to injury, and you'll sort of see that cartilage when you press on it kind of move up and down. That cartilage is considered unstable at that point. So a lot of times what you do is you debride or remove that damaged cartilage, and you get this sort of yellow tan area underneath. And this is that subchondral bone, which is bone that lives right beneath the cartilage. So you get down to this portion here. And then this would be a microfracture specifically would be to sort of punch holes in this subchondral bone to sort of stimulate a bleeding and your body's natural healing response. And then over here, you can see this is an industry-derived product that uses sort of cadaver cartilage that's sort of mulched up or chewed up, and it comes in this sort of paste that you can place within this deficit to try to sort of essentially replace cartilage. We don't naturally regrow cartilage. The microfracture, the punching holes in this, what it does is it ends up developing what's known as a fibrocartilage, which isn't as robust or as strong as your native cartilage. So a product like this would be something that tries to give you a more hardy surface, and that's more similar to cartilage itself. And then osteochondral transplant or grafting. This is done for larger lesions. So typically anything that's quite a bit larger, or an area on the shoulder of the talus where the edge of the talus is, because this is liquid or at least somewhat fluid, it doesn't sit well if it's on sort of an angle or on the side of the talus. So what you can do then is you essentially take a plug, and you can take this from an area of cartilage in the knee that doesn't normally articulate. So there's areas in the knee that don't normally articulate with the tibia. And you can take a plug from there and essentially drill out the larger lesion and then essentially set that plug in, similar to anybody who golfs when they replace the hole on the green. It's a very similar concept. You basically take a plug out and put it in somewhere else. So you have native cartilage, native natural bone underneath instead of this option. Superficial perineal neuritis. This is sort of a traction injury that can happen due to that inversion again with the foot, and that natural kind of inversion injury puts tension on this perineal nerve. There is variations to this nerve, so while this is the most common variation of it, sometimes it does start behind the fibula and come out kind of further over on the side. So although this is rare, it is a complication that I've seen in training, and can definitely be a delayed presentation. Typically this causes numbness and tingling as well as some burning sensations over sort of the front and outside of the ankle. These tend to be short-lived and tend to heal without any sort of intervention, although they can be, they can sort of nag on if it's an actual damage to the nerve itself, or if it becomes scarred in secondary to its natural course, and if it has a variation that puts it closer to where the actual damage to the ligament is itself. Peroneal tendonitis and tearing. So again, as I kind of talked about earlier, there's two tendons that are important over on this side of the foot and ankle. So you can have inflammation and possible tearing of one or both of these tendons that run along the outside of the ankle here. And these are commonly involved in ankle sprains, as they are tendons that resist inversion, which is the motion that caused the rupture of these ligaments. And you can kind of see how the CFL ligament lies directly underneath these tendons, and sort of very, very close in relation to the ATFL here. So symptoms here would be, as opposed to more of an anterior talofibular ligament, which would be more over the anterior aspect of the ankle, or the calcaneofibular ligament, which would be more on the sort of down this way. You get more swelling, kind of pain, warmth over the posterior aspect, or the back of that outside bone, the fibula. And you may have some weakness associated with this if you do have tearing. I don't have it specifically in here, but this small peroneal retinaculum can also tear or avulse or come off of the fibula here. And what that sometimes allows is these tendons to sort of snap over the side of the bone. And for some people that can be painful, as well as lead to instability. So treatments for peroneal tendonitis, and again, these aren't exclusive to ankle sprains. People can have peroneal tendonitis for all sorts of other reasons, but treatments tend to, again, consist of immobilization. So in a boot, whether that's non-weight bearing or limited weight bearing. Activity modification, again, if there's certain activities that are causing pain, it's one of those things where if it hurts a lot, you sort of need to stop or at least modify what you're doing with it. Anti-inflammatories to help with some of the swelling. Sometimes we utilize bracing, again, similar bracing that we would utilize for the ankle sprain itself. And then physical therapy, again, just to kind of mobilize the tendon. When you have these sprains and injury to the tendons, to the ligaments, you get a lot of scar tissue that can build up. That scar tissue can decrease the gliding that these tendons do through their sheath that the tendons are in. So, and then if it's something where it continues to be a long-term sort of pain or long-term instability, MRI, to evaluate the ligaments of the ankle, to evaluate the cartilage, also evaluates the tendons here, and these are commonly torn. I will say these tendons are notorious for being an incidental finding on MRI, meaning you've gotten an MRI for something completely unrelated, and they will comment on a partial tear or tearing of either the peroneus longus or the peroneus brevis. So they are commonly injured without people knowing, but when they are symptomatic, we can surgically repair them. So this kind of shows you, this is the fibula here, and then this would be the tendons that again kind of run around the back of the fibula, and then under this one obviously has a tear in it, which has caused it to sort of split over the apex here of the fibula. Basically what you would do surgically is you would go through and cut out the portion that's diseased, and then what we call retubularize. And basically what happens is these tendons flatten out when they're injured, or if they're torn, they sort of flatten out instead of that nice sort of round shape. So we can go in there, remove the diseased portion, and then retubularize, make them a nice normal round shape again. Ankle arthritis. This is, again, any one of these could be their own topic, so we'll kind of broadly hit this. But what is ankle arthritis? Well, it's decreased joint spacing due to the loss of cartilage. 70 to 80% of ankle arthritis is due to past injury. So again, ankle sprains, fractures, etc. And that is unlike the knee and the hip, which tend to be more of a true osteoarthritis or an overuse type of arthritis. Ankle tends to be due to damage, specifically to the joint itself. And the degeneration can worsen with time and lead to deformity if you have sort of uneven wear within the ankle joint itself. So symptoms associated with ankle arthritis are typically a deep pain or ache. You may notice some catching and clicking. Stiffness and swelling tends to be a pretty common finding for most people, especially with activities. Sometimes it's not so bad during activity, but it'll be the night of or the next day after increased activity. So again, right there, can be worse with periods of rest, but it may also be painful during and even present at night when the swelling really kicks in. Non-operative treatment for arthritis, typically, again, activity modifications. If there's certain activities that bother you, up and down stairs tends to be an issue for people. Long distances, long walking distances. So somebody who maybe is used to 4 miles, maybe you back it down to 2 or 1 before you really start sort of wearing through that. So activity modifications. Anti-inflammatories, again, this can include injections. This is one of those places where a steroid injection sometimes does wonders for people. Sometimes they get, an injection will last them years or a decade. Sometimes people come back in for a once yearly ankle injection just to, start the golf season or what have you during summer. Sometimes bracing is a possibility. As well as physical therapy. Again, it depends on the level of ankle arthritis, where your ankle arthritis is. If you have deformity within the ankle, kind of determines your sort of natural treatment option routes for that. And then again, we have operative treatment for this as well. So arthroscopy, like I talked about, going in with a camera and a shaver, sort of debris to remove those bone growth that people get and some of that impinging. So a lot of times when you get ankle arthritis, early stages are, swelling of the joint capsule, which we can go in and sort of clean up. And then you get this overgrowth of bone, and we can go in and remove some of that. Some people will get a big spur sort of on the front of the ankle joint that will limit the amount their foot is able to come up or dorsiflex. And we can, again, through very small incisions, go through there with a camera and a shaver and kind of take down the front of the tibia there to increase the amount of motion that they have. More extensive arthritis, or even, larger osteochondral defects. Some people have extremely large osteochondral defects and very large cysts that develop that take up a significant portion of the cartilage of the ankle joint. In that case, doing any sort of resurfacing or repair of the cartilage typically isn't a worthwhile endeavor. So the two mainstays for this otherwise are ankle fusion and ankle replacement. And I'll kind of just give you a kind of general, options that are out there as far as ankle fusion first. So if we start over here on the left, this is sort of the arthroscopy or that camera and shaver options, very small incisions at the front of the ankle. This would be an arthroscopic ankle fusion. So again, small portals, clean off the cartilage, sort of remove all the debris from the ankle joint. And then through, again, kind of small poke holes, we have access that we can get screws into the ankle joint. So, very small holes for the actual prep of the joint and the removal of the cartilage, as well as very minimal incision for actual fixation or, placement of hardware and screws for the ankle joint. This is typically reserved for people that, maybe don't have very good skin quality. And you're sort of worried about healing from a skin standpoint. Typically, you would choose something that's more minimally invasive, such as this. This is kind of the anterior ankle incision. So this is more of a utility incision that we utilize in the foot and ankle, and this would cover any of these options. So if we kind of come down here, this would be the open incision, or the open with an anterior plate or a plate on the front of the ankle. So again, you would prep them the same way. You'd have this big open incision, you're staring at the front of the ankle. You can take all of that cartilage out from both the tibia as well as the talus under here. And then you can position it and utilize a plate and screw construct instead of the sort of the percutaneous screws. You would utilize this if you had more deformity. So if you had more tilt one way or the other in the ankle joint, you would utilize more of an open approach. You can get some correction with tilting of the ankle joint with the arthroscopic approach. It is just slightly more technical, and you're sort of limited in how much correction you can get out of it. So you would tend to lean towards more of an open plate fixation construct. These are the two. There's lots of options for ankle replacement. There's many different generations and companies that make ankle replacement implants. These are sort of two. They live within the same family. So this is sometimes regarded as a revision implant for this, but this is the Infinity. These are the two that I have the most extensive training on, and the two that I would utilize. So this, again, just like in knee, you're cutting out a portion of bone and you're putting this implant in. And again, there's this space missing here. There's what's called a poly or a polyethylene, basically a real low friction, high density sort of plastic, essentially, if you will, that lives in here. It's connected to this piece here, and it allows this portion to sort of glide and function as a relatively normal ankle. You won't necessarily have natural range of motion back, but it does go from very arthritic, limited, painful range of motion to sort of increased range of motion that is hopefully pain-free. And then this, again, is typically utilized for more severe deformity. And again, can be a revision option, as it provides more robust bone to implant contact, whereas this one you can kind of see is smaller pegs. And then again, a larger contact surface within the bone here, the talus. Typically, the complications and recovery between the two are very different between ankle arthritis for fusion and replacement. Like with most implants or joint replacements, you do want the joint sort of moving. You want to rehab these relatively quickly, just because you don't want them to scar in, and the whole point of doing them is to increase motion, so you don't want to lose any motion that's available due to being non-weight bearing for extensive period of time. I will say, though, that typically in the foot and ankle, an incision like this does take 2 to 3 weeks to heal. So you're sort of fighting the incision versus wanting to increase motion. So some people are 2 weeks non-weight bearing, some people are 4 weeks, some people are 6 weeks of not putting weight on it. It kind of depends. And again, it doesn't really matter which route you go between these two. For the ankle fusions, natural bone healing is typically 6 to 8 weeks. If you've got diabetes, if you're a past smoker, thyroid deficiency, vitamin D deficiency, these are things that can prolong that and make you kind of have to stay off of it longer. So this is one of those things where we're needing bone to come back and heal to bone. So essentially, instead of a joint, you're making it one bone, essentially. Whereas this, you get some natural ingrowth on the interface here, the surface. But typically it's the fact that this is nice and sort of press fit in that makes them stay in place. So these are your options, again, for sort of more significant arthritis. And again, these individually could be an entire talk. So this is more of just a broad stroke of it.